Okay. I see Jake, Peter Kafka, Evan and Roy Savarick, Les Shelderup, Dennis Correa, John Appler, Paul Frieda, Jay Kruckman, Rich Jackson. Is there anybody else that I've missed or anybody else who wants to identify?
And Len just arrived.
Yeah, I see that.
Hey, Len.
Hi, Jake. Hi, Rick.
Hey, Lynn. Okay. All right. So, before I go around and see who would like some time tonight, I have to share some really sad news that shocked me this morning, I have to say, which Len and Jake are already aware of. But I got a note from Jan Harrington to tell me that Jim passed on the 20th of June. One of the reasons it was such a big shock to me is because he'd just written to me on the 16th of June saying that his doctors had given him 6 months, and what did I think was around that might be new that he could discuss with his doctors. And I wrote back to him he wrote me on the 15th, I wrote back to him on the 16th, and I hadn't heard back from him since then. So it was like 2 weeks, and on Tuesday's call, I was thinking, I wonder how Jim's doing. I haven't heard from him, and I was going to send him a note, and then it slipped my mind, and then Jan wrote me this morning. So I called her, and she said that they had actually gone away. They'd gone from Jersey they lived in, they had a condo, or they have a condo right on the Hudson, like up around, I don't know, it would be equivalent to somewhere around the top of Riverside Drive, 100th Street or somewhere like that, up on the Jersey side. And they'd gone to Columbia on a river cruise on the Columbia River, and Jim wasn't feeling great. He'd done one session of carboplatin, but he insisted on going. Jan didn't think he should go, but the doctor said if he wanted to go, he could go, and they went, and this was probably mid-May. And then he came back, and his breathing was labored, and he was in and out of hospital. The good news is, from what Jan tells me, he didn't suffer very much at all. He was in hospice for half a day. He needed oxygen to breathe right at the very end, which is why he went back into hospital. And it looks like the cancer blocked up his lungs. And he had a very strange disease. He had disease that did not make PSA, really didn't show up much in the bones, but he did have bone metastasis, and started to show up towards the end in some of his soft tissue. He tried lots and lots of different things. He was really courageous. Some of you may remember he went through the listeria trial. He liked Dana Rathcott very much at Memorial Sloan Kettering, but he never really shifted his care. And I think if it were me, I would have moved my care from Rutgers a lot earlier than he did. He was with, what's the guy's name? I'm trying to remember the name of the guy that he was with, but but it was a Rutgers doc who moved to work with Charles Drake at New York Presbyterian. And that was the guy that was doing the listeria trial. I'll tell you shortly. One thing that I knew, and Len was quite surprised, and Jake I think too, is that Jim was a real luminary in terms of the development of laser and fiber optics. I knew because at one point we discussed patents, and Rutgers holds several of his patents, including one of the patents that is very significant in laser surgery, laser surgical instruments. But his obituary highlights the fact that he was incredibly well recognized and well known in the field of laser optics. So he was truly one of the pioneers of laser optics. And he worked at 2 or 3 different universities before settling at Rutgers, but he was in the 70s head of Hughes' laser optics program out in California. Hughes is now Raytheon. So, but he was always very understated, and he was dear to a lot of us, and he helped, as many of you know. He was very knowledgeable regarding ED and urinary issues because he had implants and valves, artificial sphincters, and goodness knows what. And he was always very generous with his time to people that we referred to him who had issues around those subjects. And we remember him very fondly. Len or Peter, did you want to say anything?
Well, I guess I would just add to what you just said about his openness and honesty about his own treatment side effects. He would jokingly tell us that he was the expert in urinary incontinence.
Yeah.
I don't want to be, but I am. So, I'm happy to help any of you guys who feel you need help with this. Whereas, I'm sure some guys would just as soon not talk about those things. He was very open and upfront and willing to help. He was just a great guy. I never even knew he was a scientist until fairly recently when he mentioned that in the course of one of our hearings that he was a scientist. And for some reason, I just assumed he was at Rutgers teaching, I don't know, some non-scientific social science area. Simply because he never talked about his very impressive credentials.
Yeah.
He PhD in physics and internationally known, just an amazingly humble guy.
He was. He was
very sweet.
There were times I would actually refer to him as professor, but it wasn't that often.
Yeah,
but,
yeah.
And he was teaching. He had a teaching load right up through last semester.
Yeah, that's what impressed me. He kept his profession up right to the end, right through his chemotherapy. He didn't flinch. He was steady in his character. I never saw him upset or depressed or angry or. He just take things in stride. And then Rick and I had a chance to actually meet he and Jan last September at the BCRI conference.
Yeah.
I'm really glad we did meet each other. It means a lot to me when we see each other on the phone or on the.
I think he froze. Your video froze, Pete.
And
Yeah.
And your voice.
Much deeper respect, yeah.
Anyway, so there will be a memorial service at Rutgers University featuring the New York Gilbert and Sullivan players, actually, who were very dear to him. And that's not going to be on September 30th. So Jan said she wanted to wait until the faculty were back for the new semester. And so Len for sure will go. I may even try to go. I actually got to meet Jim twice at PCRI conferences 2 successive years. I think Peter did too. And he was supposed to come out to Canyon Ranch in Tucson, but he was sick, too sick to travel. That was in February, so I was hoping to see him again then, but didn't happen. All right, so let's get into today's agenda. Oh, talking about professors, look who's joined us, Professor Bill. Excellent.
Welcome, Bill.
Hello, everybody.
Hello, Bill.
I've been listening for about 5 minutes.
Good. All right. So let me run down the list, and we don't have anybody new. I'll give you telephone folks one more shot. If you'd like to identify, speak up. If not, don't worry about it. Listen in, glean whatever you can, and maybe next time. Okay. All right. Jake, anything that you'd like to talk about? Oh, yes. Didn't you go see your doctor, or you got some results or something? You said you'd have for this time.
Yeah, I did.
Okay. All right. So, Peter, anything for you?
No, I'll have more tomorrow. All right.
Okay. Evan and Roy, would you first of all, Evan, were you able to listen to the virtual group from last week?
I was was that you I was emailing with?
Yeah.
Like a few tries. Yeah. I finally got on there.
Okay. So would the two of you like to take some time to talk to us a little more about your dad's situation?
Yeah, absolutely.
Okay. We'll come back.
Okay.
We'll come back to you. I'm just do this so that I know how to allocate time. Les Shelderup, anything for you today?
Not particularly. There's a couple questions I might have, but it shouldn't take long.
Okay, you got it. We'll stop by your questions. Dennis, anything for you today, senor?
No, I am doing fine. Thanks, Rick.
Okay. John Appler, have you signed up for your new health insurance?
Almost. I'm very close to it, but because you guys, I'm much closer. But nothing for me, Rick, but I wanted to thank you for two things. One, for filling in about Jim Harrington. That was really interesting to hear. I mean, he's such a modest guy on the phone, and he always said one thing. You know, chemotherapy, it's not that bad. I mean, he's such a modest guy, and to hear about this background, I really appreciate that.
Yeah.
And I also appreciate you also commenting, honestly, too, that maybe you should have moved away from Rutgers sooner. As tough as those things are, I love when you deliver that candor because we all need to hear it.
Well, his doctor at Rutgers was Mark Stein. And Mark Stein, and he's a good doc, he's a good GU med onc. He's now working with Charles Drake, who's another luminary in the field of immunology and immunotherapy. But Mark Stein was pushing this listeria trial and pushing it. And, you know, we kept saying, well, what about something else? Oh, well, the doc wants to give me the listeria and he's keeping me on the chemo. I mean, Jim had, God knows how he probably had 20 or 30 doses of docetaxel. And you're right. You always say, oh, chemo, it's not that bad. That's exactly right. I can hear him saying.
Yeah.
But, you know, he was one of these people that tolerated chemo well, and he kept doing it, and he kept doing it, and he kept doing it. And we couldn't get him to move his treatment from Mark Stein, and then Stein left and he went to Ferrari, and we said, move your treatment, Jim. And he didn't. So whether they would have started carbo earlier had he been at a center of excellence, I don't know, but anyway. But thank you for reminding us about that, because yes, it makes me smile when I think about him saying this, it's not bad. Exactly what he would say.
Yeah.
Paul Free, anything for you tonight?
Oh, I'm good. Thank you.
Okay. Jay Krugman, anything for you tonight?
Nothing from you, Rick. Thank you.
Okay. Rich Jackson, anything for you, sir?
No, still in a holding pattern. Thanks, Rick.
Okay. Len, anything for you?
Niente, nothing.
Niente. Okay.
Boy, that
Professor
Italian's
Bill,
really paying off.
what
Those
did you say?
Italian lessons.
Yeah, I hope you're picking some up, Jake.
I got the niente so far.
Good.
And I know spaghetti and pizza, but that's about it.
All right, there's three right there.
I tell you, so how long is it going to be before I can tell people that they can learn Italian if they join this call?
We should live so long.
Okay. John, let's see, where was I? Len, did you want to say anything tonight?
I did not.
Okay.
Right.
Professor Bill, I know that you've got a significant update to tell people. Is that not true, Bill?
Oh, I'm sorry. My computer froze. I didn't realize you were talking to me, Rick. Yeah, I can. I mean, I'll keep it brief, but I do have.
I know.
Things have been happening. Yeah.
Yes, things have been happening. Bill Franklin, I see you've joined us. Is there anything you'd like to talk about tonight?
Yes, unfortunately, I have something to ask.
Okay, it's not unfortunate, and we're delighted to have you ask it.
I wish I didn't have something to ask, though.
I know you do, but we always like to. If we can support you, it's always a pleasure. Jeff Marchi, anything that you'd like to talk to us about tonight?
My hot flashes are way down since I've been a month away from my last shot, and so I'm fine. I'll let people want to hear. Thank you.
Okay. Well, I will tell you, Mr. Marchi, that we have been passing out your ice water tip like it was going out of style. I've mentioned it to at least 3 people. So
what they think?
What's that?
What did they think?
I don't know. I haven't heard back from them, but I've had several people moan to me about hot flashes, and I've said to them, you know what, guys, try ice water, because we have it on good reference that it works.
I do it 3 or 4 times a day minimum, and it stops it every time. It's great. But
okay.
I'll let others talk.
Okay. Well, we love it. We love it. That's really good. So now I've got 2 new people who have joined us on the telephone. Would you like to tell us who you are?
This is Jay Kern.
Okay, hold on.
Hold on.
Sylvester,
speak again, please.
This is Sylvester, and I apologize for being late.
No problem. And so Sylvester's on number 6, and Jay Curran is on number 7. Okay, Jake?
Yep, got it.
Yes.
And Sylvester, is there anything you'd like to discuss tonight?
No, thank you.
Okay. And Jay, is there anything you'd like to discuss tonight?
Yeah, I'd like to ask about 2 old drugs that I heard about that I heard some doctors are still having luck with.
Okay, we'll get to you. Okay, so I think I've now got, I'm going to just do one quick, I'm going to go through everybody again. I think you've got Sylvester down twice, Jake. One of those is J-Bob. Okay.
One of them's, Sylvester, would you mind speaking?
I'm coming out. I was trying to see you guys on the computer, but I'm coming out.
Okay.
Oh, okay. Okay.
All right.
No problem. You can be on a computer. It's just, you know.
That's fine. So the
I knew what I was doing. Rick didn't this time.
The Sylvester man that you have left is Jay Curran. Okay.
I have Jay Curran identified already.
Do you?
Yeah. Jay, would you speak up one time, please?
Yeah, it's testing 1, 2, 3, 4.
Yeah.
Okay, you're good.
I got it.
Good. Okay.
Sylvester was on the phone and the computer.
No, I came off of the computer, just on the phone now.
Okay. Okay. Jake, why don't you tell us about what is going on from your last visit and your test results?
All right. Well, PSA is holding at 0.7, which I'm happy about. That's been now 6 months that it stayed at 0.7. Some of my other numbers are kind of wacko. You know, RBC, hemoglobin, hematocrit, platelets, creatinine, carbon dioxide, calcium, and protein are all low. And my AG ratio is high and my chloride is high. But other than that, I'm perfect.
How low is low as far as your blood numbers are concerned, Jake?
Well, they're definitely, outside of the range. Like the hemoglobin is 12, the reference range is 13. Hematocrit is 33.9, reference is 37.5. RBC is 3.79, reference is 4.14. Platelets are low, 144, and lowest reference is 150. Creatinine, that's a weird one, 0.61, and the reference range is 0.76. But I always thought creatinine was a marker for cancer, and the lower it was, the better it is.
It's a marker of kidney function, Jake.
Yeah, kidneys. Yeah.
But I'm surprised that their range only goes up to 0.76, because normally creat normal range goes up to about 1 or 1.2.
No.
So
I'm sorry. They have it marked as low, and I was just giving the lower number of the range.
Oh, low. Nothing wrong with low.
Oh, okay, good.
Yeah.
Yeah. Now all those that I gave you, I'll just, because they're marked as low, I gave my number and then the low number that is considered the low end of normal.
Right.
I didn't bother giving you the high number.
Right. So,
and I've got a couple more that are low too: calcium, carbon dioxide, protein.
Are you taking D3, Jake?
Yeah.
And have you measured your D3 hydroxy 25 recently?
About 3 months ago.
Okay.
When we first discussed it, it's been 3 or 4 months now.
Okay. You might want to just check it again and see if you brought it up or if you need a little more.
Yeah.
Especially if your calcium is low. But what I wanted to say, as you'll hear when Professor Bill talks to us, these numbers are marginally low, the blood count numbers. I mean, I wouldn't worry too much, but I keep an eye on it. I mean, one of the reasons is because when you're on extended hormone therapy, as you have been, it does result or it can result, often does result in anemia. And so it suppresses all of the blood levels. So, you know, it's not that low that you would need to take action, but you need to keep an eye on it in case it drops much more. And I don't think it's something that, if it were me, I would be that concerned about.
Yeah, no, I'm not, Rick. I asked my oncologist about it periodically. She's also a hematologist, and she goes, no, they're okay. They're they're a little bit low, but they're not that, like you said, they're not that far out of range.
I mean, I hate to tell you what would bring them back up. I think you know.
I can guess.
You can guess. Anybody else can guess?
Yeah, we all know.
Len knows.
Len knows. Let me ask Jay Kruckman. Jay, what might bring these levels back up a little bit?
I have no clue tonight.
All right. Well, Len, why don't you tell him?
I think you're talking about Jake's love of smoking.
No, I wasn't.
Oh, no? Oh, testosterone then?
I thought you were too.
No, yeah. I was talking about Jake's other love, exercise. Thank you, whoever that is. Yes.
Somebody's whispering exercise. I hear it.
Yeah.
Exercise.
There you go. Yes, a little exercise would bring those numbers right back. Like, a exercise bike in front of the TV or something like that. So, but I'm glad that it's good that your PSA is holding like that, and it's really good. It's really good.
Thank you. I'm happy as long as that stays low. I'm good. I'm comfortable.
Okay. Would anybody else like to talk to Jake about these numbers or contribute anything?
Jake, are you taking any supplements?
Yeah. Well, I take a number of medications, but I do take vitamin D and calcium. Bill.
So you may want to consider adding in folic acid and vitamin B12. Those should help your red blood cell numbers anyway go up, and hemoglobin numbers.
Okay, folic acid and B12. They're both over the counter, Bill.
Yeah. Yep.
Okay.
But again, Jake, I mean, this is they may help, but I would discuss it or just talk to your doc about it. Just don't add it.
Okay.
Yeah. Well, I should have added that.
Okay. Next time I see her, I will ask.
Right. B12 is oftentimes suggested for people that, and I know this isn't your case, but people that are vegan often have to take a B supplement. I forget the reason why. Len, do you know about that?
Well, I think B12 is most commonly found in meat.
Mm-hmm.
Right. Iron, right?
Not so much in vegetables. Okay. Iron too, yeah. Yeah, you should probably have your iron level checked and your B12 level checked.
Okay, I'm looking here. I don't think they're on here. That's not part of a normal test, is it? Or those aren't part of a normal test?
No, not really.
Yeah, I don't see them.
So it might be a good idea to test them and see, and then if they're low, then you supplement.
The other reason we don't, I don't want to take too much time, but the other reason I don't worry about it, and my doctor doesn't worry about it, is because it varies from month to month. Mm-hmm. Like last month, it was pretty much almost everything was normal. Mm-hmm. So, it's just, I don't know if it has something to do with my diet or whatever. But, if it's consistently low, I'm sure she would say something.
Mm-hmm. So do you feel like you're having an abnormal month, Jake?
I guess. I thought I was having. I'm more tired than I was. That's for sure.
Well,
I'm feeling kind of ragged out.
Yeah, that could have something to do with it. So get yourself tested. And thanks, Bill, for the suggestion.
Yeah, thank you, Bill.
So given that we're talking about these issues and to give you a frame of reference, Bill, why don't we bring you up now? I also don't want to lose you. I don't want you to feel so tired that you've got to drop off and go to sleep before you have a chance to talk. Why don't you talk a little bit about what you found out about your own situation and your levels, and that'll give folks a sort of frame of reference for when they need to start worrying.
Oh, I'm sorry.
About anemia.
I lost you there for a short bit, Rick, but I'm assuming you want me to talk about my situation.
Yeah, what I was saying is, Bill, what I was saying was that yours would be a good contrast in terms of your blood count levels to Jake's, and people will get a better feel for when they need to start worrying about their blood count levels.
Right. Okay. So so my counts are quite a bit lower, and I'm hoping that you have the numbers in front of you, Rick. Do you? I don't.
I think I might. Just give me a second, and I'll tell you.
Yeah, I'm going to try to dig them out too.
For some reason, my computer is also slowed down to crawl. Okay, let's see if I have them.
No, here, I think this is it.
Well, yes, I do. I have some of them.
Yeah, my hemoglobin was down to 7.9. I think. Is that what I told you,
Yes,
Rick?
that's what I've got. Yep.
Platelets to 43,000 per microliter.
Right.
And what else? There were other ones in there.
Your red, I don't have it, but your red blood cells were very low, and your white cells were very low.
Yeah. So anyway, they were all of my blood counts were low, and almost certainly this is due to the drugs that I'm taking as part of the clinical trial that I told you guys about a month or so ago. So the clinical trial involves treatment with olaparib, which is what I've been treated with for the last 3 years, but it's losing its effectiveness. And an investigational drug called AZD6738, which inhibits a protein called ATR. So ATR is a DNA damage response protein, and so the basic idea for this trial, the hypothesis the trial is testing is that if you combine inhibition of Parp with olaparib, which leads to the accumulation of double-strand DNA breaks in your chromosomes, with inhibition of this damage response protein, ATR, that this will lead to an excess of double-strand breaks in tumor cells that will be sufficient in numbers to cause them to die. And the reason why it works specifically in tumor cells and not in normal cells is because the pathway that ATR functions in, and I think I told you the last time, this is a pathway that my laboratory actually discovered about 15 years ago, runs in parallel with a second redundant pathway that remains intact in most normal cells. So you have these two pathways that lead to the same place. They're both defective in tumor cells, one because mutations occur in almost every type of tumor, and the other pathway is knocked out by these drugs. But then in normal cells, the first pathway is intact. And so when you knock out the second pathway with the drugs, it doesn't have much of an effect. So I hope that's clear. So these, I've gone through one 28-day cycle of treatment with these drugs. And when I went to Dana-Farber, which is where the trial, where I'm being treated as part of the trial, last week, they determined that my blood counts were exceptionally low. And so I had they transfused me with 3 units of whole blood before they let me leave. And hopefully this is going to carry me through the next 28-day cycle until I come back to Dana-Farber for more drugs. If it doesn't, then so I should also, I'm not being very articulate today, I'm sorry. The reason why the blood counts go down is because the both PARP inhibitors and inhibitors of ATR cause myelosuppression. In other words, they knock out the production of blood cells. And so if my counts go down again at the end of the next cycle, the plan is to lower the dose of the ATR inhibitor and see whether or not, you know, my system will tolerate that better. So that's pretty much where I'm at. We don't know yet how effective the trial is going to be. It generally takes 2 cycles before that becomes clear. And last week at the end of the first cycle, I had blood work done, but not the extensive testing that will involve scans that will occur at the end of the next cycle, at the end of July. And so, you know, then we'll have a much better idea of whether or not the combination of drugs is working. But what we do know at this point, based on the blood work, is that my PSA is stabilized. And it was doubling at a rate of about once every 3 weeks, which is horribly fast. So I'm pretty happy that it's remaining pretty much, you know, that it hasn't changed. I think that, and I think my oncologist at Dana-Farber agrees that this is encouraging.
Yeah, that is good news.
Yeah. So if it, you know, if it doesn't work, then as I think I told you the last time, I discovered about a month ago that the pembrolizumab treatment that I was undergoing before I entered the trial, which we didn't think was working, turned out to be working. So I have that as a backup.
Yeah, I was going to ask you that, Bill. They did not start you back on that yet, huh?
No. You know, we need to, you know, wait until the end of the second cycle in the trial to see whether or not this is working. And if it's working, then we'll just stick with it.
Oh yeah, for real.
It will take me. Yeah, I have to say I'm concerned about the low blood counts. You know, if we have to drop the dose, then of course that's not necessarily going to be as effective as it would be otherwise.
Right.
I guess the other issue that I ran into, I think since the last time that I talked to you all, was that I had an episode of severe bradycardia. My pulse rate went down to about 39 beats per minute, which is not too far above the inviolable range. And we don't really know why. My hypothesis was that it was once again related to the drugs, but which have been reported to show some cardiac toxicity. But according to Atish Chowdhury, my oncologist at Dana-Farber, this is not the type of cardiac toxicity that they saw in phase 1 trials. And so he doesn't think that it's related to the drugs, but I'm not convinced. The fact trial I had to have an extensive cardiac workup, which included EKGs and echocardiograms, and the cardiologist concluded based on those tests that my heart was equivalent to that of a 40-year-old, which makes sense because I've been really active all my life. But it really doesn't make sense now that all of a sudden I'm having these cardiac issues.
So Bill,
during the trial, so I'm suspicious that it's the drugs.
Bill, could the low blood counts have been responsible for the brachycardia? I was talking to somebody last week, I forget who told me that they'd had episodes of AFib and brachycardia when their blood counts were very low.
Yeah, that's a good possibility. And that's something that I talked to Atish about also. And he agrees that it could be contributing to it, but he thinks that there has to be more to it than just low blood counts.
Okay. Well, we need, well, first I do want to open it up. We need a little more education, but we don't have time for it today, but hopefully next time you're on. But I am, for a long time, have wondered why these PARP inhibitors give rise to myelosuppression, but we know they do. And, you know, one of the things that occurred to me is that since this drug that you're on, the AZD6738, potentiates the PARP inhibitor. In other words, it's kind of like a turbocharger for the PARP inhibitor.
Yeah, exactly, right.
Maybe if it's making the PARP inhibitor more effective and more efficient, and we know that the PARP inhibitor causes myelosuppression, then maybe there is some sort of relationship there.
Yeah, I think that that's likely to be the case. I mean, I can tell you what the underlying mechanism is really quickly. PARP works at DNA, at the structures that are involved in replicating DNA, and cells that are dividing need to replicate their DNA. So, that includes blood cells.
Mm-hmm.
So, what I'm not clear about is why, there are a lot of cells in your body that are dividing.
Mm-hmm.
But most of them are not, but, your intestinal epithelium, for example. So I'm not sure why there isn't an effect on those populations, but it makes sense that these things would cause myelosuppression to me based on the fact that these proteins all operate during DNA replication.
Okay.
Bill,
Well,
do you take any supplements? For example, do you take folic acid or B12?
Oh yes, that's why I mentioned it. Yeah.
Okay. And do you take also?
That was recommended to me by my oncologist.
It doesn't make a difference. Does it help?
There's so many things going on. It's really hard to tell. I don't know.
Right.
I mean, things are really benign. They can't really hurt you. I shouldn't. I mean, that doesn't mean you shouldn't talk to your oncologist before you start taking them. But I don't. I think it's. My feeling is there's no real harm in taking them, and hopefully they'll have an effect.
Okay, is there anyone else that would like to say anything or ask any questions of Bill before we move on?
Jay
Yeah,
Kern.
Bill.
Go ahead, Jay.
With the bradycardia episode, what were the symptoms, or how did you know?
I was working in my garden, and I had an episode of orthostatic hypotension, which is when I was bending over planting stuff, and then I'd stand up and be so dizzy that I'd almost pass out.
Okay.
So I called my my primary care physician, and she brought me in and did an EKG, and then told me, "Do you want to go to the emergency room in an ambulance, or do you want me to bring you?" So, and she did bring me. That was amazing. You can't ask for much more from a primary care physician than that they actually bring you to the hospital.
And somebody else had a question for Bill?
I did, Rick. Bill, it's Len. So the 7.9 hemoglobin, was that before they gave you the 3 units of whole blood?
Yeah, that's correct.
Oh, okay. Did they check it afterwards?
They measured it right after they transfused the 3 units, and it was up to just short of the low end of the normal range.
Oh, that's good. And did you feel more energized?
Hold on, Len. Just so that everybody knows that the normal range, I think, is 12, is it? Or 14, 13? What is it, Jake? The normal range for hemoglobin?
It's 13.
For hemoglobin, it's according to LabCorp, it's 13 to 17.7.
There you go. Okay, 13. I just wanted to make sure people knew the actual number. Then go ahead. Sorry.
So Len, in answer to your question, yes, it did. I mean, I had no idea how much I have had the horrible problems with fatigue, over this last month, and it made it an immediate difference. After I was transfused, I felt, like I had much more energy. Now it's going.
What about the bradycardia? Did that improve after the infusion?
The bradycardia pretty much ended during the, I was in the hospital for 2 days after that happened, and it seemed to stabilize while I was there, and I haven't had an episode since then. So it didn't. My pulse has been running about 50 to 55, and it didn't seem to change much after the transfusions.
Good.
Okay. Takes a licking and keeps on ticking, right?
That's right.
Right. Thanks.
Okay.
Yeah. So just one final comment. I don't want to take up any more time, but if anybody has any questions about the ATR inhibitor, this is turning out to be a big deal. It's going to be a very effective drug, I think. And, based on the reports that I'm hearing from all my oncologist friends, and especially in a combination with other drugs, including pembrolizumab. So, if anybody's looking for treatment after, some of the more conventional treatments have failed, if you want to talk to me, I can help steer you toward a clinical trial.
Bill, isn't this where you're supposed to declare all conflicts and interests and all of that part? Isn't this where you're supposed to say that you discovered the channel, or repeat that you discovered the effective channel or something?
I think you're probably right. Yes. I don't. Okay. I can tell you that I am. I'm not biased, despite the role that I've played.
Okay. All right. So thank you, Bill, and it's good to hear you. And we're all glad you're a little bit more energized.
Thank you.
So we will move on. Evan and Roy. Roy, we know that you're in a place where you need to possibly select your treatment, that you were somewhat short of information. Why don't you tell us what has transpired since last week, and Evan, crystallize your questions and we'll do our best to answer them.
Yeah. Evan, do you have those questions? Like, nothing has really transpired. On Thursday, I'm going to see Dr. Rossi again and had some questions for him, and in San Diego. And on the 19th, I'm seeing Turner in Los Angeles. And in between those two, on the 12th, this is all of July coming up right now, I'm taking my second hormone shot.
Right.
But listening to, and hope to get some more information from those folks, and then kind of go from there. Listening to the replay, Evan had 2 or 3 questions. And Evan, are you still there?
I'm here.
Okay, why don't you ask there were 2 or 3 in relation to, and I'll jump in if I think we're kind of going astray a little bit. So ask away.
Okay. So my big takeaway from the advice you were giving to my father is that he needs to gather information before he starts any treatment as far as the radiation is concerned. But so to my understanding is, since he started taking the Lupron, any of the, like the Axiom or any of the scans would be ineffective as far as showing anything. So my question is that true, or are there different exams or different scans you could do, or is it too late since you already started taking the Lupron?
So I'll answer this quickly, and then I'm going to let Peter answer it because this is right in his bailiwick. But the answer is that the Lupron, a month's worth of Lupron, is probably not going to make any difference to an Axiomin scan, and unlikely to make much difference to a gallium-68 or the 18F PYL scan either. What the thinking is that the Lupron may possibly reduce any evidence of metastasis by possibly starving cells, killing them off, and therefore reducing what you might see on a scan. But it just doesn't happen that quickly. So, after a month or so, you're still going to see, and most of the guys who have recurrent disease have often, and are doing these scans, have often been on hormone therapy for quite some period of time, although some of them, like Peter, have stopped taking for a while. But if it were me, I wouldn't be concerned about doing that scan after having done just a couple of months of Lupron. Peter, what would you say on that?
Yeah, I asked Roy the other day what his PSA was. He wasn't sure at that point. So if he's getting his second shot in a week or two, that means he's been on for 3 months. It did drop his PSA kind of in half. It was still over 1 last time he had it checked. I did my gallium-68 scan. I wasn't on ADT at that time, but my PSA was below 1.0. It was down at 0.75. So, and it was effective. It did pick up what I was looking for. And in your situation, Roy, it might it might be effective because you have no imaging at this point. I mean, you've done no imaging. I was in my situation. I was looking for something that had not appeared yet. I knew something was going on, but I didn't know where it was or what it was. But in your situation, you need to kind of find out, why the Gleason score was that high, where the activity is. And my guess is, after you talk with Turner or Rossi, they should be able to let you know the effectiveness of this, because I'm sure they'll be interested in finding out, what's going on, where things are going on, before they start treatment or want you to do treatment.
Okay. So, go ahead, Ev. So I was in the meeting with Rossi, and he sounded pretty, ready to do. He said, let's do the 3D imaging, the 3D MRI. So we had the mapping, and he sounded ready to do. He said 3 weeks after we have that to do the radiation, which was counter to my takeaway from listening to the call last week, which was before you start doing that, you don't want, potentially to start radiation, and then you could have done other alternative treatments first.
So Evan, is your question why we feel more information is needed before you start treatment?
Yeah, I guess it's more specifically, so if you do the proton or the radiation, what does that prevent you from potentially doing?
Okay. So here's the big issue, I think, with Roy's situation. First of all, he's never had a proper biopsy, and some small amount of Gleason 9 was detected through the TURP. Now, he also has a very low PSA. So there's no real knowledge as to where the cancer is. And that Gleason, that specimen hasn't even been reread. So if somebody else read that and say, instead of it saying it was a 4+5, say they read it as a 3+4. And we found out that, in fact, your dad has very, very little cancer. Then
So that maybe my father didn't say. So it was read originally as a 4-5, and then we did send it to. Do you remember where we sent it to here in New York? They reread it as a 5-4.
Hopkins.
So it was read twice.
Right. Okay.
Hopkins.
Yeah, I'm sorry.
Right.
So, but we still don't know the extent of the cancer.
Mm-hmm.
And I think that it's really important to know the extent of the cancer. So let's just say, let's take the worst case. Let's say that the cancer is outside the capsule, and it's in the lymph nodes, or maybe even worse, that there's evidence of some bone metastasis. Then the issue is, well, would you kick off with what is the best thing to do first? Would you start by doing a radiation therapy, and what type of radiation therapy? It may well be that what might be more appropriate, that a different type of radiation therapy might be more appropriate. So to me, there's just not enough knowledge. I don't know. Let me ask the other guys what they think.
Okay, so
I think doing a biopsy after radiation, I think, is a really iffy thing. I've never heard of anybody doing it. Maybe it can be done, but I think getting primary radiation in the prostate and prostate bed and then doing a biopsy afterwards doesn't make sense to me. And Roy was telling me the other day that he saw his cardiologist, and his cardiologist said that all you really need to do is stop the blood thinners a couple of days before the biopsy, and you'd be good to go with a biopsy. So I'm just saying that I think a good oncologist will steer you toward getting an MRI guided biopsy before you start any other kind of treatment. And I think if you really talked straight to Dr. Rossi, he would back down from starting treatment too. I mean, I think he's an intelligent guy. I don't think he's going to risk things by just starting treatment without knowing what's really going on there.
So Peter, would you recommend? Definitely recommend, because this last week was the first time it was okay to do a biopsy because the clots are gone and I could back off the blood thinner, and they said 2 or 3 days I could do whatever I want, and one day after the biopsy, just go back on the blood thinners just to be sure for a month or so. But will the biopsy give us what we need, or is it biopsy plus Rossi's MRI, or what will give us a clear enough path forward through getting enough knowledge?
Can I say something here? This is Bill Burhams. I know for a fact you cannot have a biopsy after radiation treatment. You can, but you have to wait somewhere around 18 months. The biopsy will be just unreadable. And I know that from my own experience. I was accidentally biopsied a second time after radiation treatment, and I was told by multiple oncologists at both my home institution and at Sloan Kettering that was a mistake. So I think it's really critical to get the biopsy first before radiation treatment, if that's what you're considering doing. And the biopsy is, it's going to provide really critical information to help you decide how to proceed beyond that point.
So the biopsy gives you additional information that the reading of the from the slide from the TERP, it would give you more. Okay.
Well, the problem, Evan, is we don't know the extent of the disease.
Right.
Yeah. The biopsy will sample in multiple places in the prostate. So, the biopsy I had was had 16 cores. And, the tumor is not going to be in every one, or not necessarily. It will tell you both how large the tumor is, which will be reflected in the fact that tumor tissue is seen in most or all of the cores. And it will tell you there'll be a lot of, usually there's a lot of heterogeneity in the Gleason scores in different parts of the tumor. And so it will tell you how much heterogeneity there is. So there's lots of information that the biopsy will provide that the TERP will not. And as Rick is saying, it's, mostly information about the extent of disease.
Okay. So in the meeting with Dr. Rossi, my interpretation was that the 3D MRI that he would do would have answered that, but I guess obviously that's nowhere near as informative as doing a biopsy, I would assume.
You need that to direct the biopsy. You need the 3D MRI before the biopsy. Both will give you good information. Both will give you essential information.
Okay.
Matter of fact, I think it might be especially important for him to have the MRI first, so he can have a targeted biopsy, so they won't have to get 16 cores, or especially considering he was on blood thinners. The fewer biopsies cores that they do, probably better off he'll be. And if they have the MRI, which will radiographically show where the lesions are, they can, like in my case, I had an MRI done and there was cancer all over, but all they needed to do was take 6 cores just targeted to lesions on 3 on each side, each lobe of the prostate.
Right.
So, yeah, I think that would benefit you.
Yeah,
Okay,
that's
so
I mean I wasn't in on the call last week, so I don't. I'm reading between the lines about the what's going on here, but the MRI will provide information about where the tumor is, but it won't give you any information about the the grade of the tumor in different places. So, and as Len said, it will allow them to focus the biopsy. Once they know where the tumor is, then they can limit the number of cores so that if that's an issue, they can, potentially avoid problems there.
okay. So
Yeah. So in
yeah.
go ahead. So in doing the
All
biopsy, how important? I mean, is it okay if the same person who did my TERP 3 months ago? I mean, that was the oncologist. Does it have to be someone very, very specialized, like going up to UCLA or Dana-Farber, or could this be done in the oncologist's office that I used for the TERP, who did a very good job with the TERP, by the way? But what's your thought with that?
I think that you could probably have the biopsy done by anyone who has a lot of experience doing them. But then the more important thing is that the cores are read by a pathologist who is who's associated with a major cancer center, or where they have a lot more experience. The critical thing won't be the biopsy. I mean, that's just it's a technical issue. The really important thing will be reading the biopsy to determine exactly what what the tumor is all about.
Yeah, I mean, I
got
just
an
want
answer.
to hold on a second, Peter. I just want to say one thing there. What is important if you're going to do a fusion biopsy is the quality of the MRI equipment. So you have to make sure that somebody has got excellent MRI, at least a 2 Tesla, if not a 3 Tesla MRI machine, because they're going to do a fusion biopsy. And so they want to overlay and they also have to have the software to do that. So a local urologist office may not necessarily have that. Peter, go ahead.
That's exactly what I was going to say. I mean, we can't give medical advice here, and we're not doctors. But if it was me, I would not go back to the local urologist in Steamboat Springs, Colorado, because I doubt he has experience doing MRI guided biopsies. Because I think you have to go to Denver to even get that machine. Anyway, so that would be my take. I would, if you're in California, I'd call UCLA up and see if you can get an MRI guided biopsy there while you're there.
And I agree. I think I was out of line there. I agree with you guys about that.
So we need to sort of wrap this up because I want to leave enough time to get around to some other people. But I mean, I think the key issue that I would be asking myself, Roy and Evan, is, well, if I had all this information, would it change my treatment choice? And I think that it may change my treatment choice depending on how much cancer I find and where I find it. If I had a small amount of cancer that was 4+5, then yes, maybe I would be fine with RASI radiating my my prostate. And probably because there's a 4 in the number or a 5 in the number, you probably want pelvic girdle radiation, which I'm sure Rossi is talking about. So either way, just because what you see there is a 5+4, you need pelvic girdle radiation, plus you need treatment of the gland itself. The question is, what is the best combination? Is it proton beam? Is it some sort of brachytherapy, either seeds or HDR plus pelvic girdle radiation? Is it SBRT plus pelvic girdle radiation? And the other thing is, and given that this emerged from the, your sample emerged from a TERP, just to be certain and absolutely sure that the cancer hasn't invaded any other vessels, that you don't have any cancer around the bladder neck, for example, because those, or you want to know to what extent the cancer might be outside of the gland, because if there are, if there's any evidence that the cancer has grown more than what you're seeing, then it may change your discussion. The other thing is, I don't know if you've have you done bone scans and CT scans?
Yes, they were both negative. Thank God.
Okay, great, excellent. Yeah, I see that. I have it on my notes that the CT scan is negative. And,
Rick, I have a question that could be answered in one sentence, and we won't take any more time. I read about small cell cancer as well.
Yes.
And Evan spoke to a how do you describe him, Ev?
Oncologist.
All right, he's a prostate oncologist, and he said when they send these samples in, either through Steamboat or I think we sent the other one to Epstein, and you know, to do a check. If they routinely check for small cell cancer, and if they don't say there is small cell cancer there, they just don't comment on it.
Correct.
That was the feedback we got. Is that reality?
Yeah, it's absolutely correct. I mean, the report from Epstein would identify your cancer as adenocarcinoma, I suspect. They're supposed to identify what type of cancer they see. And if they saw any cells that they thought were cancerous cells that were not adenocarcinomic in appearance, they should have identified that. And since you sent that sample to Epstein, he would have said so. However, there wasn't a heck of a lot that they looked at. So that would be a question with 5+4 and a very low PSA. That would be a question I would ask after I've done a full-blown biopsy, a fusion biopsy.
Okay.
But I think the takeaway from this is not to proceed until you've had a biopsy of your prostate.
Right. How quickly do you get results back when you do a biopsy in general? Is it a quick sort of thing?
It's usually a week, five business days, but you know, they can accelerate it if there are issues, but it's usually a week. And but that would be from the local lab, and then you probably would want to send it out to Epstein again.
Right. Okay, I think we've taken up enough time. Great feedback. Thank you, everyone.
Okay. If you need to talk more, you know, Evan or Roy, you can call Peter, you can call me, and we can help you some more.
Okay. Thanks again.
Thank you.
Yeah, good luck Thursday.
Yeah. Thanks, Peter. Thanks, Rick.
And be direct. Ask the questions. You know, go in there prepared to ask questions.
Yeah,
I know. I'm not shy.
Not only ask the questions. is this the meeting? Is this the meeting with Turner that you're doing next week?
On Thursday this week it's Rossi, and 2 weeks later it's Turner.
So with all of these doctors, write your questions down and hand them a hard copy, or as Peter has suggested, email them the copies ahead of time and give them a hard copy when you walk in. That will ensure you get all your questions answered. Good advice for everybody on the call. Don't just have your questions in front of you and ask them the questions. Make sure they have a copy of those questions too.
Yeah, that's great. That's great. Thank you.
Okay?
Nice
And
question.
if you want Peter or I to look over the questions, we can do it. Okay? All right, Les.
Yes, thank you.
Les, you are up.
Okay, can you hear me?
Yes, we can.
Okay, last time we spoke, you asked about some lab readings that I didn't have yet. I was going to get in the next day or two. Following the previous treatments that they had, the testosterone level was less than 7. PSA was less than 0.1, which means, I guess, undetectable from on both counts.
Right.
So what that means, I don't know, other than it hasn't started up again yet. The other thing that I was inquiring about, there was one of the suggestions was that I go on Xtandi. So it's a debate between going on Xtandi or doing this additional pelvic radiation that the Mayo Clinic is recommending. Was there anyone else in the group that is currently on Xtandi or has been?
Anybody doing Xtandi right now?
I'm on Xtandi, Rick.
Yeah, go ahead, Jake. Yeah, you've been on it for a while. Please.
Yeah. What was the question?
Just wondering how things went, what the side effects were, and how did you handle it, and so forth.
Okay, well, this is Jake. I've been on it for about a year now, and if you heard earlier, it's keeping my, in addition to Lupron, it's keeping my PSA down to around 0.7. It's never been below 0.5. The side effects are a lot of fatigue, some mental fog, unsteadiness on my feet. I had to watch myself going up and down the steps because it's very easy to trip or to lose my balance. And of course, the sexual side effects, that goes with the Lupron. I had that long before I started the enzalutamide. I lost more hair, not on my head, but on my body, my arm hair, leg hair, just underarm hair. It just all went away completely. But the two main side effects that I've had was the fatigue, the unsteadiness, and the weakness, and I forget what the other one was that I just said.
How long have you been on Lupron?
I've been on Lupron since June of 2012, so it's exactly 6 years.
Wow. Okay, and on Xtandi?
A little bit more than 1 year.
Okay, so you can tell the difference in what was attributed to Lupron versus Xtandi.
Well, it's a cumulative thing. I mean, I always tell people when they're having side effects with Lupron, I tell them, chances are you'll get used to it. The side effects, a lot of times, at least they did with me, they lessen in severity. But then you add the enzalutamide and it kind of just magnifies whatever side effects there were before.
Okay, because I'm concerned about the, I haven't started on the Xtandi or anything yet, but I've been on Lupron now for, well, several months.
Right.
And to me, the fatigue or lack of endurance is stressful.
Right.
And I'm guessing from this, the Xtandi will just make it that much worse.
Well, everybody, I'm not going to say that, but most likely it will. Everybody responds differently. Everybody responds differently to Lupron. Everyone responds differently to enzalutamide. But, the chances are probably good that they will get worse.
Yeah. Okay.
If I was a betting man, and I am, I'd say, yeah.
Okay. Thank you. I appreciate your input.
Oh, you're welcome. Good luck.
Thanks.
Does anybody else?
Did they offer you the opportunity to do Zytiga as opposed to Xtandi?
That had been mentioned by one of the doctors, but that was about it. The main one was they were stressing was Xtandi.
Okay, from my personal experience, I've been back. I did 18 months of Lupron and Casodex, but now I'm on Lupron and Zytiga, and I'm 3 months in now and have very little fatigue. I'm religious about exercising, and I think that helps. But the other possible advantage is that with Zytiga, you take a small dose of prednisone,
Yeah.
which can, help fight the fatigue too. Because I'm looking for the fatigue and I don't find it. I've been kind of turning over every rock the last several months, and I'm just not finding it yet. I'm doing okay. So maybe it'll bite me tomorrow morning. I don't know, but I find Zytiga is very tolerable in my situation.
Okay, that's interesting. This one doctor I had seen in Omaha, Nebraska, this Dr. Luke Nordquist, had strongly recommended that Zytiga and what was that companion? Prednisone. Yeah. Right. So that would go right along in line with what he had been recommending.
So who recommended the Xtandi, the enzalutamide?
Well, it was just a local doctor that said, well, he said either the Zytiga or the Xtandi.
Okay.
So it wasn't really pushing the other one. He just mentioned, well, how about this?
Right. So I was going to say to you, it's really a toss-up between Xtandi and Zytiga. The Zytiga has to include prednisone, the other does not. But again, I come back to the issue we've discussed several times, is that you probably need a new quarterback at this point. And have you given any thought to switching your care to another genitourinary medical oncologist?
Yes, I very definitely have. That's been on my mind constantly. The thing is, when I was initially diagnosed, I was given less than 2 years to live, and that was pretty definite. And like pack your bag. I had stayed locally, and then I started with Dr. Kwan at the Mayo Clinic, and I'm now at about 5.5 years. I have been under the care of Dr. Kwan. So even though I am very reluctant to go on with what he's recommending doing at this point, it's very difficult for me to switch horses in that he's been successful. He's gone from less than 2 years to now it's 5.5. So it's hard to argue with success. But
well,
I
would say a couple of things, Les. I mean, first of all, you were diagnosed, as I recall, with I mean, you had seminal vesicle invasion, you had a Gleason 10, and you had some lymph node involvement.
Yes.
You didn't have any bone mets, correct?
Not initially, no.
Right.
But
So
I did have in the spine, and they did some cryoablation on 2 spots in the spine that were cancerous.
yeah, but that was in January of 2018.
Yes.
Right. So anybody who told you that you had 2 years to live, when were you first diagnosed? 2014, right?
13.
2013. So anybody who told you that you had 2 years to live based on some seminal vesicle involvement and lymphatic involvement, I would ask them where they were getting that information from. Because most people would be told worst case, 5 years. Worst case. So I don't think that 2 years to live was a very reliable number. That's my first point.
Well,
go ahead.
Some of it was from other experience, and my family physician had made some comment to me the last time I was in there that he had had another Gleason 10 patient that was diagnosed a long time after I was. And I think he anticipated my next question is, hey, can I get in contact with him? Because he said, well, he passed away a long time ago. So,
and did he have bone mets?
I'm not certain what he had. All he said that he had Gleason 10 and it was advanced.
But Les, that's the problem. I mean, you know, the guy may have been diagnosed with Gleason 10 and he may have had metastasis all over his body. We don't know.
Yes, right.
Right? So what I'm saying is in your situation, 2 years wasn't very realistic. And most doctors would have said to you, if they were pushed, they might have said 5 years, but I don't think so.
What makes you think it would not be working?
Jay, can you please mute Paul Frieda?
Yeah, got it.
So I don't rely on that 2 year number. More likely with some lymph node, and that lymph node involvement, was that known in 2013, or was it just that you had in 2013 a Gleason 10 with seminal vesicle involvement?
The latter. They had done some testing and they hadn't detected. They assumed that I had involvement elsewhere, but for the tests that they were using, they had not been able to detect it.
Okay, based on a Gleason 10 and no knowledge of lymphatic involvement, I don't know where that 2 year number was coming from, and it would bother me intensely, and I would be talking to the person as to where they found it, or would urge somebody to ask where that came from. Secondly,
well, I found out later that this doctor had seen one other Gleason 10 patient in his life. So I assume he was basing it on that one other.
So let's not, at least in discussing it on this call, talk about a 2 year life expectation, because I don't think, you know, to me that is a confabulation of facts. Okay. Secondly, and I just want to relate something to you that was told to me this week. And again, I want to be really careful because I know that Dr. Kwan has been very successful with a number of patients, including a guy that I respect very well who's often on this call. But Dr. Kwan is not a GU medical oncologist. He's not even a medical oncologist. And he favors a lot of intervention. And I'm not saying take your care away from Dr. Kwan. I'm saying add a genitourinary medical oncologist. You need to add a genitourinary medical oncologist. And you know, there are a number of physicians and departments at Mayo that will not work with Kwan. That's why he sends his people out to other oncologists. And it's sometimes, you know, he has very unusual methods. Now, God bless him for giving you the time that you had. I don't take anything away from him, but in your situation, you need a bona fide genitourinary medical oncologist on your team. That's not medical advice about taking drugs. That's just navigation and good sense. And I think that most any educated patient advocate that understands prostate cancer would say to you at this stage of your disease, where you do have bone mets, where you've had several recurrences in your lymphatic system, you need a genitourinary medical oncologist on your team. I mean, I don't want us to sound like a broken record here. And if you want to persist in doing what you're doing and seeing Juan, God bless you. But you need a really good opinion from somebody who's very well qualified in this, in the management of this disease, and who is a medical oncologist and not a surgeon.
Okay, very good. Thank you.
Okay. Does anybody else want to add anything before we move on? We've got a little bit of time, just we've got 2 other folks to get to, so we have a little bit of time. Anybody want to add anything?
Well, Rick, I agree with everything you just said, and Les, I would tell you this, and I imagine everyone on the call will agree. We've never heard of anybody who's diagnosed, no matter how dire the diagnosis initially, that didn't survive at least 2 years. That, you know, that I agree with Rick that whoever told you that, like to know where he got information like that. But in fact, most oncologists today would say that almost everyone can make it to at least the 5-year mark.
Well, but Len, I mean, we've had people on this call who have who have lasted less than a year, sadly, but they've been diagnosed with extensive metastases and high Gleasons.
Okay, I did not know that.
Trevor Doherty, God rest his soul, was one. You know, he lasted 11 months. We've had a couple of people, but I cannot ever remember anybody who did not have identifiable metastasis at diagnosis. I can't remember anybody with a 2-year prognosis.
Well, I think Frank Kelly was one who was told, you know, that he only had 2 years, 3 years to live, and he ended up making it 5 or 6, didn't he?
Yep, he did. And I told him from the outset, from the very first day, I remember as I sit here talking to him eventually the first time, because it was Lisa who spoke to us forever and a day. We couldn't get him to talk, and he called me up. I was sitting on my stoop in San Francisco and telling him, you have longer than a year to live.
Yep.
And oh, I don't know. And I was saying, you know, with your record, because he did. He lasted 5 years. So, anyway, Les, I'm just giving you some perspective here, that you're going to be around for a long time, man, and it'll be even longer, hopefully, if you add a good doc to your team at this juncture. Anyone else?
Yeah,
I'm definitely working on it. Okay, thank you.
Les, this is Bill Burhans. I was told twice that I only had a year or less to live, and that was 4 and 3 years ago. And here I am, and I expect to have at least another 2 years.
Right.
So
and,
I think
and you had metastasis, correct?
Yeah, right. I really cannot emphasize how much I agree with Rick that you should look for a medical oncologist.
All right, let's move on. I think Les has heard us, and Les, keep coming back. Don't be up. We're not picking on you, but don't be upset if you hear us again. And we just want to guide you. We want to see you get the best possible treatment. Don't dump Quan, but add somebody else.
Okay, I certainly appreciate. I'm not ignoring your advice. In fact, I'm looking into it, but I am trying to investigate a little more. I'm still trying to give Dr. Quan a benefit of the doubt, but I've got a visit with him coming up later this month, and I think I'll make a definite decision by that time. Thank you much. I appreciate it.
Okay. Bill Franklin, and then we'll finish up with Jay Curran. Bill, you're up.
Yeah, can you hear me?
We can.
Yes.
Yeah, I was laying back because I exercised so hard today that I was really about to fall asleep here. But not that everybody's not interesting. It's just I exhausted myself.
Good. That's a good reason.
Jake's still on the call? Yeah.
Yeah, I'm still here, Bill. I heard you whispering in my ear earlier.
That was for your benefit. Yeah. Yeah, so this weekend I had something happen that has not happened to me since the beginning of this this condition that I have. So I say blood in my urine, but the first thing that happened was Saturday. I had some pain in my groin for about an hour. It was a couple times it was kind of stabbing, but then it was kind of just a constant dull ache, and it went away. And a little bit later, I felt like I had to go to the bathroom, so I went in, sat down, nothing happened. I thought I was urinating just a little bit, like a couple of dribs and drabs came out, and there's nothing like that's happened to me since, way back in the beginning.
Mm-hmm.
So I'm just sitting there, and I can't defecate, and I feel like I have to, and I feel like I think some urine's dribbling out, and so I stop and I get up and I look down, and it's the toilet bowl's red. I mean, it wasn't like blood in my urine. It was blood. It was bright red coming out of my penis. That freaked me out. So, I cleaned up, went about my business. About an hour later, I had to urinate. So I went in.
Did we lose Bill?
Bill, we can't hear you. If you're there, we cannot hear you.
I think we lost Bill.
He's showing live.
I know.
Yeah, but he's not. Well,
I know.
He is mute.
Yeah, Bill. If you can hear us, we have lost you. Are you there? No, I think it must be at your end because everybody on the call is still getting good connection.
yeah, it says he's offline.
Yeah. So we'll come back to Bill. He'll probably call in. Let's run over to Jay. And there's somebody else that joined late who's on the telephone.
That's me because I had to call in and just use the computer without it.
Yeah, there's somebody else too. There's another person.
Yeah, it's me, Eric Bookbinder.
Eric. Oh. Okay. All right.
Always good to hear from Eric.
Always good to hear from Eric. I don't know if we have time to touch base, but we will try. Okay.
Yeah, it's okay.
All right. Jay. Let me just check. Bill, are you back with us? No. Okay. Jay, why don't you pick up the slack here?
Can you hear me now?
Yep.
Oh,
we can hear you, Bill.
My connection dropped out for some reason. I have no idea. It just came back.
Okay.
I guess I don't know how much you heard, but
we heard up to the point where there was bright red pee the first time, and then an hour later you went back and you peed again, and then we lost you.
Yeah, so an hour later I went back, and it was pink, but there was like blood clots in it, and And then that cleared that, and then later in the day it was kind of clear, and then Sunday morning a couple of times, first couple of times I urinated, it was pinkish, but then it was clear for the rest of the day.
Mm-hmm.
So my doctor, I called her, I went into her lab, gave urine. They tested for infections. They said, no, I don't have any kind of a urinary tract infection or anything. But they did detect blood in the urine, but they told me to go to my urologist, who is a genitourinary oncologist, just to mention that. Anyway, and said that said go to him. He'll do more more in-depth testing on a urine sample. So I have a appointment with him next Monday. Unless he has a cancellation, I'll go in. Okay. But I believe that someone in our group who had this issue long after treatment was Jim Cameron, if I'm not mistaken. Unfortunately, Jim's not here to talk to us anymore. So
no, Jim had the issue, and Professor Bill has a lot of experience, but I also do. So let me just give my perspective, and first of all, I want to tell you about. I want to go back way before I had prostate cancer, and I know that I had blood in my urine many times, and usually it was associated with a kidney stone. There were times that I had blood in my urine from exercising very, very hard. So I used to train on an indoor track when I lived in New York, in Manhattan, and there were a couple of times when I trained at night on that track with a bunch of other people, and that gave rise. So I never really bothered too much about blood in my urine because I always thought it was, something which was highly manageable. After I had my treatment and my radiation, I would have I never had huge amounts of blood, but I would have periodic incidences of some blood in my urine, and I would wait till it happened 2 or 3 times, and then I'd call my doc. And eventually he did a cystoscopy, and what he saw was radiation cystitis. And how long now is it since you completed your radiation in 16, right? Sometime sometime September 16, something like that, maybe.
No, it was just after I know the July 4th holiday. I remember because I took I didn't get a treatment on the July 4th, and I had to come back for that additional week. So, yeah. It was 2016, right about this time.
Right.
When I finished.
Right. So, now's the time. There's usually pretty good delays on this. So, there's a good chance, and I'd be talking to my docs about this. Could this be radiation cystitis? And it is, then it's not that serious, and you just live with it. Now, could it be worse things? Could it be something wrong with your bladder? Could be, but that's why they do the cystoscopy.
Right.
And we have people on this call who have, are probably going for world records in terms of the number of times they've had cystoscopies. Isn't that right?
Yeah,
Dr.
I've had one.
Professor Bill? Yeah. So, Bill, Bill, are you still with us?
Yeah, I'm still here. I said I had one.
No. Professor Bill.
Oh, Professor Bill? I don't hear him.
Yeah, he's grayed out. But my own recommendation would be, if it were me, I'd be talking to the doc about do I need a cystoscopy, Bill? And I wouldn't be worrying too much.
Right. Yeah, I
So,
had one
Rick,
back in the beginning when I had the incident after my surgery where I tore the stitches. So,
Oh, that's right. I remember. Yes, yes, yes. Yeah.
Rick, I'm back. I had to, my and I had to turn it off. So, Bill, did you exercise a lot right before this happened?
Thursday night was my last karate class. I mean, it was a pretty good exercise session, but this happened Saturday afternoon, so I
Yeah.
didn't associate the exercise with the problem.
So I had exactly the same experience in that what appeared to be all blood, no urine came out of my penis. But it was after I had spent the day cross-country skiing for about 30 kilometers.
Mm.
And when I called my oncologist, he said that it almost certainly was related to the exercise, as Rick was indicating too.
Right.
And I mean, it could be radiation cystitis, but which I also have, but it never turns my, it's never accompanied by so much blood that
Right.
it, appears to be nothing but blood that's coming out.
Right. Okay. Well, I'm not too worried about it because we've discussed it in this group, and I've read up on the different issues that you can have. So, and of course, after going through all this, I have the philosophy that I'll wait and see. I don't start worrying about it until
Yeah.
doesn't do you any good, right? So talk to the doctors, get the
Exactly.
results, and then start worrying. So
Yeah. I mean, I think it's a good idea that you're going to follow up on it, but I wouldn't be too worried.
Bill, what type of radiation did you have?
I want to say EBRT, but
You didn't have brachy boost?
No.
no,
Okay.
no.
No, because
was,
Bill had surgery
external.
first. This was.
Yeah, I had the prostatectomy first.
Oh, okay.
And the surgeon, she told me she didn't get it all. So.
Right.
And then after, I had the my PSA went up really fast right after surgery. So.
Right.
Within they do the first test like 6 weeks after surgery. It was a 0.6, and then less than a month later it was 2. So and I went right on to Lupron, and then when he felt I was significantly recovered from the surgery, like urinary incontinence and everything,
right.
which bugs me because I was completely continent prior to radiation treatment. I fully recovered. I wasn't wearing pads or anything. I didn't have stress incontinence, and it started again after radiation treatment. So we all know that radiation can affect it too. So
Is there
I thought
anyone
I was
else?
going to be one of those lucky ones.
Is there anyone else that has had any similar experience that they'd like to mention?
This is Les. I had somewhat similar experience after radiation, and they detected or concluded that it was damage from the radiation treatment. But my urologist put me on the pentoxifylline, and he's been on me had me on that ever since. And supposedly it does some good. It's a pill for something else, but he said that it's supposed to do something to help, and it had diminished it, and then it has been gone ever since. But that appeared probably 2 years after the radiation treatment.
Yeah, I'm right at 2 years right now. So.
Yep,
This is Sebastian.
That's when mine happened. Was about 2 years. Yep.
Go ahead, Sylvester, quickly, because we want to get to.
I've had 2 of these episodes. I'm not on any medication, and my episodes appear to occur about approximately every 5 years.
Well, I'd be happy with 5 years before the next one.
And Sylvester, do they know? Did they give you a diagnosis, or are they you just figure it's 5 years, it's going to happen?
Well, after going through the exams, my urologist determined that it was caused by the radiation.
Okay. 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 So I do want to move on. We've got 5 minutes, and we should I would like to try and touch base with Eric. So we may go over 5 minutes or so. But Jay, you're up. You have a couple of questions for us?
Yes. I was talking to someone, and they were saying that these old drugs, some people are using them, and they're getting some luck with them. Avodart and Leukine, or have they gone completely by the board?
And who is it that's using them?
In a support group, one of my support groups, metastatic group.
I know what doctors are prescribing them. Can you tell us?
I can't pronounce his last name, but he's in Walnut Creek, California.
Okay. So Avodart is not an old drug. Avodart's a current drug, and it is used. And it's also called finasteride, and it's what's called a 5-alpha reductase drug, and it controls dihydrotestosterone.
Hey Rick, I'm sorry to interrupt. This is Eric. I have a strict 7 o'clock cutoff, so I'll touch base on the next call.
Okay, Eric. Yeah, I'll call you.
All right.
Okay. So 5-alpha, it's a 5-alpha reductase. It controls dihydrotestosterone, which is kind of a turbocharged form of testosterone. I'm sure you've heard of double blockade and triple blockade.
Yeah.
So it is what is used in triple blockade, and it's still currently used by some docs. Now, the last person I heard that tried it was Dr. Steve about a year and a half ago, because he had an unusually high level of dihydrotestosterone, and they tried to bring it down. I don't know that it was particularly successful. So it's would you want to add it? I don't know. Who are you seeing now? Agarwal? Did you switch to?
Yeah, I'm seeing Agarwal, and I have not talked to him about it.
So you could talk to him about it and see what he says. I think, given that you're on Xtandi, although I think Steve was on Xtandi, or
no, I'm on Firmagon and Zytiga and Prednisone.
Yeah, given that you're on Zytiga, I can't remember if Steve was on Zytiga or Xtandi at the time, and they did add it. But I think that before you added it, you'd want to measure your dihydrotestosterone. I mean, if your testosterone is very low, but you have an abnormally high level of DHT, which is what Steve had, that was why they added it. So, but it is a drug that is used. It's not a drug that's likely to be effective for most people with advanced prostate cancer. Leukine, I don't know enough about it. The last person I know that used Leukine was back around 2010, was a good buddy of mine who sadly passed. And he was getting Leukine. Len, give us your 2 cents on Leukine.
Leukine is a drug that's often given with chemotherapy, because chemotherapy will suppress your blood cells, particularly white blood cells, platelets, and Leukine will boost your white blood cell production which will help protect you against bacterial infections. It does have side effects. A lot of guys get bone pain and sometimes even kind of disabling bone pain, so they have to stop it. But most docs would not prescribe it just routinely. I think one of the few exceptions was Snuffy Myers. I think he used it fairly routinely, but that's unusual. In and of itself, it has absolutely no anti-cancer activity. It just helps boost white blood cell production.
Oh, okay.
So, I mean, if your white blood cells are very low, maybe that would be a reason to do it.
Yeah, that's why the guy that I mentioned, he was taking it because his white blood cell count was low, and it was part of that therapy.
It will not affect lymphocyte count, though. Lymphocytes are what we need to fight the cancer.
Mm-hmm.
Is it the DHT? How do you get that test? Is that easy to get?
It's a blood test. They can measure it. I don't know how, but you can get your DHT measured.
Okay.
And it's a blood test, and I know that Steve got it. I remember Steve getting it measured.
Okay, thank you.
Usually your DHT is 10% of your testosterone. So if your testosterone is around 20 or 30, your DHT should be around 2.
Yeah, mine's down around 6.
Your testosterone is?
Yeah.
So, you know, you should have insignificant DHT. If you've got a high level of DHT, then there's something going on.
Okay.
Okay. Pleasure. All right. I guess we're done for the night. Hopefully we got around everybody.
Rick, can I just
Yes.
ask one question of Len? Len,
yeah.
Have you ever heard of patients being prescribed erythropoietin to boost red blood cell?
Yes.
Yes, I have heard of that. I remember talking to my oncologist at Sloan Kettering years ago when I first went on hormone therapy, and I said to him, well, how low would, my hemoglobin started dropping, and I said, how low would you let it go before you felt I might need EPO, erythropoietin? And he said down to like 7 or something, something very low. There is some evidence that it can actually promote cancer growth, EPO.
Oh,
so that's why they're kind of reluctant to use it, but I'm sure some docs will. It's a good subject to discuss with your oncologist.
Yeah, it just, as you were talking about Leukine, it occurred to me that this was something that I hadn't considered before, but yeah, I'll talk to them and see what they say.
Yeah.
Are you considering competing in any cross-country races or bicycle races, Professor Bill?
Yeah, it's an illegal drug.
Bicycle racing? Oh my God! Just mentioning the word bicycle sends chills up my spine.
Oh, okay.
Because
but, cross-country racing, we wouldn't want you to come in and win your age group and then they take it away from you, Bill.
Right, that's true. Yeah. All right. Thanks, Len. I appreciate it.
Sure.
All right, guys. Next meeting is the 10th, and we will see you all then. And if anybody needs anything urgent in between, don't hesitate to call us. All right.
Good night.
Okay.
Good night,
Thanks.
everybody.
Good night.
Good
night.
Just a reminder to everyone, the inner conversations will not be meeting this week, this Thursday. I mean, this Wednesday on the 4th. Next meeting will be the 11th.
That's right. Happy 4th of July, everybody.
Yeah, you too, Rick. Thanks.
Happy
Thank you.
Thank you. Good job, Len. Thanks.